My name is Matthew Gores, and yes, I'm going to be speaking a little bit about the international refugee crisis that's been unfolding. So I thought I would start off with just giving a brief overview and snapshot of about where we are right now with this crisis, as well as talking a little bit about its origins and how it came to pass, as well as how it kind of smoldered and developed as it has. And finally, kind of wrap up with just how the United States and how the European states are going to be responding to this crisis. I'm sorry. Can you hear me better? Okay, so I'll try and project a little bit more. So then I'll just wrap up with some information for providers for anyone who would be caring for these refugees after relocation to the United States or elsewhere in their lifetimes. So this global humanitarian crisis is probably the largest and worst in any of our lifetimes. About 280,000 migrants arrived in the European zone in 2014 alone, with 500,000 expected by the end of this year. This is majority Syrian, Afghani, Iraqi, as a result of the conflicts in those areas, but really has given new urgency recently as a result of just political and advocacy groups pushing for a larger and more robust response, as well as security concerns following the Paris attacks, and overall just the larger health and security concerns of the migrants themselves, as we're seeing more and more maritime disasters occur as migrants are taking worse and more dangerous routes to try and get into Europe. So really, to place this in perspective, I think it's important to go back to the origins. As we're all aware, the Syrian war is probably one of the more violent conflicts of the past decade. It started in 2011 following the Arab Spring protests and has really smoldered ever since as kind of a multi-sided conflict. In addition, while the Syrian crisis is the greater crux of this crisis, there are other conflicts in the regions which have kind of driven this entire crisis. And in addition to the Libyan war, the Iraq war, the Afghan war, as well as other crises in Somalia and Nigeria. So really focusing on kind of the larger conflict, the Syrian civil war has already claimed the lives of hundreds of thousands of Syrians and displaced outside of the country about 4.5 million Syrian refugees, with about double of that internally displaced. That places the total displaced population for Syria at about 12 million, and at a population of 22 million, that's over half the country displaced from the homes that they began with in the conflict at the beginning. This is largely contributed to probably the largest amount of refugees in world history, quite honestly. There's nearly 60 million refugees in the world today, about a 40% increase since 2011. I should say 60 million displaced people, just to be more accurate. Out of those, about 4 million are refugees from Syria in particular, and a 250% increase just since 2013, and have now overlapped Afghan as the largest refugee population in the world. But again, there are multiple conflicts driving this, and just this is another snapshot of another conflict. Libya was actually a large hub before the conflict in 2011 for migrants in the area, for both Africa as well as the Middle East. It was actually a pretty strong economy and served as a magnet. While that happened, they actually had some central authority to keep from these maritime kind of concerns from occurring. They had port authority to keep people from going across without permission to Italy, or non-sanctioned immigration. They had Coast Guard to stop people from getting into dangerous waters. But after the 2011 conflict, there really has been no central authority allowing those borders to be essentially opened and to allow for this flow. So this isn't by any regards encompassing, because there have been multiple conflicts throughout this region which have kind of driven the overall displacement and the kind of cycle of repeated displacement that a lot of these refugees have suffered. So not only has the Afghan and Iraq war, but in Nigeria, Somalia, Sudan, ongoing conflicts have just brought refugees who have found some stability in their neighboring countries to a constant cycle of repeated replacement, which has really caused a lot of frustration and pushed the origins of refugees finally moving from just an adjacent country to try and find more stable areas as in European nations. So just to kind of give you an idea, this is just kind of showing the need across the world. This is the asylee applications for 2015 for places in the Eurozone. So just as a distinction, asylees are folks who have actually gone to the country that they are applying for asylum within, while refugees are usually displaced and then are requesting to enter that country with permission and with additional resources. So this is just speaking specifically about Syrians for a moment. There are about 800,000 asylee applications since 2011, but about 3/4 of that have been just in this year. And currently there are about 100 to 150,000 applications per month since October, which is actually nearing kind of the actually U.S. hiring rate, which if that adds any weight to this. So overall, as you can kind of tell, that this has placed a lot of demand and a lot of urgency amongst asylees and refugees to find more stable area. The makeup of the folks who are actually getting into the Eurozone are about half Syrian, 20% Afghani, 7% Iraqi, as well as many refugees and asylees coming from Africa, Pakistan, and the neighboring countries. So the good news is that the majority of asylee applications are being accepted, especially for Syrian refugees. But that as you kind of go, as this continues to unfold, it's really not being considered enough. If only half of the applications of asylees for 500,000 people are being accepted, that still leaves a large portion of people who have not actually found some stability through this crisis. And so as this developed, it really started off with the Mediterranean maritime crisis, where initially after the Libyan war, most refugees were trying to find entry into Europe through the Mediterranean. But as that became more and more difficult, areas through Greece opened up. And really the entire Eurozone is an open interstate kind of transportation system. And really after entering Greece, actually under legal authority, when a refugee gets on a train, gets on public transportation, that provider, that transporter is obligated to get them to the destination that they promised them to, which has led for a complete disbursement throughout the Eurozone. And so the biggest brunt of this has been in Greece initially, but Germany just this last year overtook with the number of asylees within their country. So this is a little bit out of date because it's just going up until September. Germany actually has 200,000 asylees that they have now accepted, with an additional 300,000 refugees, meaning that they have in total since the beginning of this crisis accepted about 500,000 displaced people worldwide. This is also just kind of showing the overall trajectory. Hungary was one of the smaller countries per capita to start of getting asylees along with them. So really, it shows that the smaller countries are having a disproportionate ability to actually facilitate these asylees. And in Italy alone, it's increasingly dangerous for these asylees to even attempt to arrive. In our first slide, we talked a little bit about how many maritime disasters there were. There was actually 9 notable refugee maritime disasters from 2007 to 2014. It's now been 22 just since April, with about 500 people who have lost their lives and thousands that are missing still. So this is all to kind of a little bit of a loaded way of kind of comparing to our response in the United States. The United States accepted at the beginning of this year 70,000 refugees from varying places in the world. About over 1,000 were only from Syria. Later this year, just before, I believe this was in September, the White House announced that they would take 10,000 specifically extra refugees over the next 12 months. So it's undetermined where exactly these refugees will be relocated. Usually the resettlement programs attempt to place refugees near family, near like-minded cultures. So these are kind of the top 10 areas that are expected to accept refugees. But about 1,000 to 4,000 are expected to come. 100 to 400 are expected to come to Minnesota. So just a little information for providers who are going to be caring for these refugees. Before their arrival, all refugees undergo medical screening by the International Organization on Migration. They are required to undergo screening for communicable diseases as well as unstable medical conditions before they arrive. These include pulmonary TB with PPD testing for pediatric populations and chest X-ray imaging for adult populations, HIV and RPR testing, as well as mental health screening to make sure that there are no unstable either suicidal or homicidal ideations that might pose their own place the refugee at their own risk or place the people they're transporting with at risk. And then finally, just before departure, they are treated empirically with antimalarials if they're coming from an endemic area, as well as antihelminth therapy for either strongyloides or schistosomiasis if that's an endemic area as well. But this process is extensive, and even though these Syrians are undergoing a more rapid processing system, this on average does take about 2 years to fully process a refugee, both not only from a medical standpoint, but from a social and financial standpoint. After being evaluated for medical examination, they have 6 months before that is eligible for. However, if at 6 months and 1 day that they have everything else processed, they have to undergo another medical screening, which could take months to actually perform. They are also screened by the United States Department of Health, the United States Department of Homeland Security, the UN's High Commission for Refugees, as well as the IOM themselves. So this is just to kind of give you a little bit of an idea that when people are concerned about the security or the potential risks that refugees really pose, it's been a pretty thorough process to date. So on arrival in the United States, the CDC recommends a battery of tests for screening of both communicable diseases as well as some non-communicable diseases within refugees. So this is the recommendations, basically a blanket for all newly arrived refugees that will receive medical screening within the first 6 months of their arrival. Based on their country of origin, sometimes they recommend additional strongyloides, schistosomiasis testing, but again, if they have been treated ahead of time, usually that is not really considered. And then as well, it is recommended that they undergo mental health screening. So especially in refugee populations, depression, PTSD is rampant. And there are recommendations from the CDC on their website on templates on how to address these issues. But it's also not really recommended to be pushing these subjects, even though they are difficult, as PTSD can kind of manifest later after arrival. But I won't talk too much at length of that, because I know that's kind of the subject at hand tonight. So finally, just some specifics about Syrian refugees that we might be seeing. While there's kind of an emerging health profile about specifics that the Syrian refugees have been exposed to, there have been reports of higher than expected TB in Syrian refugees in Lebanese camps, about 40% higher than the predicted models. In addition, there have been cutaneous leishmaniasis outbreaks in Aleppo, and I believe there was about 12,000 just in the past year. But just a potential note, Syria before the conflict actually had very wide health coverage. And so about 80% of young Syrians had been vaccinated for Hep B before the conflict. But that can obviously be disturbed now that the conflict has been ongoing for several years. Non-communicable diseases have been reported in older refugees. There's been refugees have been stating that they can't even ambulate. About 10% said that they couldn't leave their home as a result of disabilities. But just a reminder that the older refugees, just like older Americans, can come with non-communicable diseases, and that diabetes and hypertension are rampant. And then also just kind of speaking again more about mental health, PTSD and specifically gender-based violence has been a large concern within Syrian refugees, with one study showing about 31% of female refugees reporting some sort of violence to their person. But the last point I just put up here is that the CDC has built more refugee health profiles that are available online. So you can actually go to the CDC's website and look at specific refugee health profiles for Iraqis and for other refugees that might be involved in this crisis that you could get more specific information about. So just to kind of wrap up things, again, this is probably the worst humanitarian disaster in our lifetime. There have been a lot of responses that we've had to respond to as a medical community over the past several years, but this is probably one of the larger and more complex ones that we'll be asked to be involved in. It's already started to show that there are rampant underserved populations throughout the world, even before this crisis. There was already about 40 million displaced people before the crisis, and that is now obviously increased. This is the Zaatari refugee camp where about 800,000 people currently reside.
Question?
Yes.
When does a displaced person get called a refugee?
So technically, a refugee by definition has left their country of origin.
So outside the border.
Mm-hmm. So within their, this is in Jordan. So it's technically a refugee camp for not only Syrian but Iraqi and Afghan and Pakistani primarily. But internally displaced persons or people are usually what they are considered folks who are still within their country of origin, and then refugees are ones who have left. Asylees are usually the folks who are applying for asylum within the country that they've gone to, while a refugee could be someone who had gone to Lebanon and then applies for entry to the United States. So just some kind of final thoughts, and this is just a little bit of a plug on my end. I really enjoyed the Virchow quote that talked about how physicians are the natural attorneys and journalists for the poor. And I think that while we all come with some understanding that we need to be advocates for our patients, we don't always have to be on the steps of the state capitol to advocate for them. And I really enjoyed this quote by Atul Gawande talking about how people talking to people is still how norms change. There's been a lot of half-truths and right-out lies talking about refugees in our political discourse right now. And I really don't think that we have to be screaming at each other to change that. I think in our day-to-day interactions with our friends, with our colleagues, with the people we'll be seeing in the holidays or other patients, we can make our case that refugees deserve better care and that these disenfranchised populations deserve more autonomy and more power than less. And so I'll just leave with that and leave the floor open for any extra comments or questions on that.
So refugees that get to the United States have been screened at refugee placement centers overseas, is that right?
Yes. So usually refugee camps are placed either near or have hospitals actually within their borders. And so the International Organization on Migration within the country will actually go to these specific regional areas and have refugees meet them at these hospitals for these screenings.
So how many actual places internationally do those screenings happen for people that end up in the United States?
Thousands. I mean, there's just as many screening locations as there are probably refugee camps themselves.
But there's a limit on the number of total refugees that come to the United States each year.
Specifically the United States, yes. But during these medical screenings, the International Organization on Migration is not a United States organization. It's an international cooperative. So when these people are screened, those are the recommendations for the United States entry, but not everywhere requires that, like Canada or the United Kingdom. So they might have a specific other set of recommendations. Not everyone might need to get HIV screening, but they need some form of medical screening, and once they're medically cleared, they can be accepted into the country that they're applying to.
And there are limits per country for the United States, is that right? Country of origin?
Not necessarily. So they just set a, within each year's appropriations, with each year's budget, they budget for how many refugees they can accept. Actually, back in 2000, just after 2001, we were up to 100,000 per year that we accepted from really anywhere. But specifically, since September, the White House set aside 10,000 slots specifically for Syrians.
Has the influx through Italy, across to Italy, stopped, or is it just not receiving any publicity anymore?
It's still occurring. I think there was Operation Triton, which is now gone, is tried to kind of, because it's in international waters, it cannot be completely within the Italian Coast Guard to actually take care of these situations. They don't want to wait till to get into their maritime space just to deal with the issue, because a lot of them are lost at sea. So Operation Trident is actually is funded by a nonprofit, but has international cooperation to kind of facilitate an international waters Coast Guard to help help mitigate that. So it's lessened because of that intervention, but it still occurs. And really the reason they've kind of lost their superlatives being the number one country to receive is that it's now kind of shifted more be a land base. So most refugees are coming in through Greece and then migrating through there.
But there's still 2,500 arriving on Lesbos a day, I've heard. Coming across the water, 5 miles or so across the water from Turkey.
I'm sorry, in Greece or in Italy? I'm sorry.
Greece.
Oh.
I'm saying you were talking about the land movement.
Oh, yes.
But I think I saw that about 2,500 refugees are coming to the island of Lesbos, Greece, per day from Turkey.
So there still is maritime attempts at crossing. I think it's just been, if we're saying what's more common, it's just become more common to cross through land. Turkey has an open door policy with Syria still to allow influx. I believe there's actually 2.2 million refugees within Turkey itself. And then from there have gone more inland and used land routes just more commonly in the past year than they have been used in 2014 when the maritime were kind of the more, I guess, public forms of that.
Is Turkey doing anything to keep them from crossing into Europe?
Well, I do know, and I'm not sure if it was Turkey itself or whether it was Greece. There was actually physically a fence built between within the strait. On the opposite side of the strait. So I don't believe Turkey itself. I'm sure they are, but I can't think of a specific thing that they're attempting to do because they do have an open door policy with Syria to actually physically, for the stated purposes of allowing refugees into their country. So. Any other questions? Okay.
One other question. What percentage are Muslim? Or are they like 95, 97% Muslim and the rest Christian? And
you know, I don't know that off the top of my head. I'm sorry. So. Thank you,
Thank you, Matt, for that update. We'll continue now with our main program, and the title is from Mike Pitt. For those of you who know Mike, he's always comes up with some very good titles for our presentations. And tonight, the title is Mental and Dental, Two Often Overlooked Areas in Global Health. So it's really great to partner. We basically partner in pediatrics with our pediatric dental colleagues, and really it's good to be doing this together tonight. So first of all, I'd like to introduce Dr. Elise Sarvis. I hope I'm saying your name correctly, Elise. She completed dental school at the University of North Carolina, Chapel Hill, my alma mater too. So, and then she moved to the West Coast and completed her pediatric dental training at the University of Washington, where she also did a master's in public health. So great combination there. So she came to us as clinical assistant professor in the Division of Pediatric Dentistry, and she's teaching residents and dental students here at the U. So the title of her talk is Dentistry in Developing Countries.
Let's see if this works. Wonderful. Thank you for that kind introduction. I am by no means an expert in global pediatric dentistry or dentistry in general, but I thought I would share some of my experiences and some low resource settings that has kind of shaped dentistry and kind of gives you a taste of what it looks like in the rest of the world. So when we think of dental disease, most people think of dental caries, holes in the teeth and cavities. In the US, it's the most common chronic disease of childhood. It's 5 times more prevalent than asthma, more common than obesity, and 20 times more common than diabetes. In the US, it's a significant public health crisis. For the process and the paradigm that we work on for dental caries and how they come about is first, we need a fermentable carbohydrate. These can be cookies, these can be any starches. So goldfish crackers are my favorite ones that parents love to give kids that also are involved in this process. The second thing you need is a cariogenic bacteria, so Streptococcus mutans. These two combine to make acid that sits on the surface of teeth and starts to wear away the outer surface of enamel and eventually can cause a cavity. When you combine this with dietary acids such as juices, and over time, you can get dental disease. So dental caries start out as a small hole on the tooth surface, and eventually the bacteria get inside the tooth and can progress down into the bone around the developing tooth. And these are pediatric teeth. Once that infection has gone down into the bone and gums around the tooth, it can cause an abscess, and occasionally it leads to cellulitis, which can then become a dental medical emergency. A lot of people don't think of cavities as really a significant public health crisis or something that needs to be addressed, but they actually come with a significant amount of morbidity. There's pain associated with it, difficulty concentrating in school. If your mouth hurts, it's hard to listen to the teacher. Difficulty eating and speaking, difficulty sleeping through the night. If the infection gets so large that you need to remove the tooth, you can then have early loss of teeth that leads to future crowding, which might lead to braces, which are very expensive. Infection can also cause damage to the permanent teeth in children and has often resulted in life-threatening infection. Some people are surprised when I tell them that children die because of dental disease. What this looks like in the world is that the United States is not alone. Worldwide, dental decay affects 2.4 billion people, and in the recent Global Burden of Disease study, it was the most prevalent condition of all of them. So if you think of all the global diseases and things that can affect us, dental decay was actually the most common. Millions of children have untreated decay, which is not only a measure of dental disease burden itself, but also a measure of access to care. So if you have untreated decay, there's something preventing you from getting those cavities fixed. And overall, it was the fourth most expensive chronic disease to treat. So we're not really great at measuring dental decay throughout the world, but in 2015, I'm glad this lecture is this year, we finally had our first kind of glimpse of what dental decay looked like throughout the world. This is a map, and I know the countries are too small, but it shows prevalence of dental caries in primary teeth. This map is mostly based on some modeling done at the University of Washington and other institutions, and it's also based on very few studies per country, so we don't have a lot of information out there. To get dental information, to get this information, you actually physically have to have someone who's trained in diagnosing dental caries, so typically a dentist or the dental equivalent in the home country, go and actually look at a mouth. And so for adults, this can be kind of easy because they're very cooperative, but for children, not so much. And you also have to find these people or see that they're coming to an academic medical center to see this disease. If you're even able to look into a mouth, what you can see might look like this, which looks nice and pretty and healthy. But unless you're taking radiographs, which a lot of these studies don't include, you might be missing a lot of dental decay. So those little spots are dental decay in between the teeth that you can't see in the mouth. So given all of that and what we know about the paradigm for dental caries, there are also a lot of non-biologic risk factors. One could be low socioeconomic status, so and all the information that comes with that. Also, if you have low income or no dental insurance, it can be really expensive to get these cavities treated or even screened or looked at. If the family doesn't have good oral health knowledge or literacy, they might not know exactly what dentists mean when they're talking about it, or might not know what their medical provider means when they're saying, you should go see a dentist because your child has decay. There are lots of cultural attitudes throughout the world. A lot of places just don't value teeth in general or don't value primary teeth. I grew up in Eastern Tennessee, and it's kind of the paradigm there that you lose your teeth at 50 and you get dentures. And so it's a cultural attitude that doesn't actually have to play out. If your health infrastructure is such that you don't have dentists, or it's very expensive to see a dentist, or you're a displaced person and can't see a dentist in the refugee camp, that can also affect your caries risk status. If you don't have any education regarding the importance of oral health in regard to overall health, or if you're just not able to access care. So like I said, I'm not an expert, but I've had a couple of opportunities to study outside of, sorry, my mom sends me dental comics every time they come in the mail. So I've had the opportunity to study once in 2010 in a country called Moldova, and we'll get to that, and once in 2011 in a country called Kenya. So I'll share my experiences in the dental care that I was able to be a part of there. So Kenya is a country in Eastern Africa, sub-Saharan Eastern Africa. It's a former British colony and home to 45 million people. About half of Kenyans live in poverty, and the most striking statistic for Kenya is that there are only 700 dentists in the country. This works out to one dentist for every 60,000 people. In the US, where it's one to every 1,500. So they have a big access to care issue. They do have a dental school. It started in 1978. And it's 5 years, a dental degree is 5 years after high school. And so it's modeled on the British system, so it's a Bachelor of Dental Surgery. They've recently added some specialty degrees, including oral surgery, prosthodontics, pediatric dentistry, and periodontology. Oral surgery is the most common by far because that is a specialty that deals a lot with trauma, and Kenya is one of the most highest concentrations of vehicular accidents in Africa. So they have to put a lot of jaws back together, which it's good that we have a lot of oral surgeons for that. To address this disparity of only 700 dentists in the country, in 2001, they started what is called a community oral health officer, which is a 3-year program after high school. Community oral health officers are based in district and provincial hospitals within the Kenyan healthcare system, and their goal is to provide restorative and preventative care. They also provide oral health education and are just kind of the officers and managers of their district or community to evaluate the disease, see if there's anything coming up and things like that. Which is interesting because they are basically a mid-level provider, like your physician's assistant or advanced nurse practitioner of the dental world. And Minnesota is actually one of the only states, it is the only state in the United States that trains dental therapists, which is a mid-level provider. So a lot of their primary occupations go back and forth. So these are both taken from like the Kenyan law and the Minnesota dental statute on what they can do. So they're tasked with diagnosing and treating simple dental disease, performing small, simple extractions, carrying out temporary fillings, or in Minnesota's case, permanent fillings, and doing cleanings and placing preventative measures like sealants and fluoride, and also writing prescriptions for antibiotics and analgesics. In Minnesota, they're well regulated. Most dental therapists work under direct supervision of a dentist. Cohos are completely different, and they work in the community unsupervised. There's just not enough dentists to supervise them. For caries prevalence, we just don't know a lot. We have one study of adults that almost 6 teeth in their mouth were decayed, missing, or filled. So had either been treated or had a cavity. So that's a lot. So a typical adult has between 28 and 32 teeth. And so 6 teeth is a lot of teeth. Children in urban areas had fewer decayed, missing, or filled teeth than children in rural areas. But again, this was based on a couple studies, and we just don't really have a good idea.
Question.
Yes?
Do you know, are there countries in the world where the kids don't have any caries?
There are no countries where no children have caries. However, the Scandinavian countries do a really good job with prevention early on, and so their caries rate is very low. Yeah. It is a completely preventable disease. Yeah. Kenya is the first sub-Saharan African country to decide that they wanted a national oral health survey report. So last month, this is really exciting, the Ministry of Health, the School of Dentistry, and the Wrigley, like the chewing gum company, came together. And they've been planning for over 2 years, and they've just started to send out their first officers into communities, villages, all throughout the entire country to take a look at things and see what the state of their dental disease is, which is exciting. Because you really can't fix where you're going until you know where you've been. Besides caries, Kenya has a lot of really interesting cultural practices that have to do with the teeth. This is one of the guards who worked outside the school I was at, and his name is Sammy, and you can see he's missing this lower incisor here. In Kenya and a lot of Eastern African countries, tetanus is very prevalent, and so it's evolved into their cultural practices and coming of age ceremonies to remove some of the lower incisors. This happens, so if and when usually they get tetanus, when the jaw locks down, you're still able to get food in between the teeth. And so if you can go out through if you can like survive your tetany spasms, then you won't become malnourished. So I was like, why is everyone missing bottom teeth? So this is why. And then right here on the right, this is a permanent canine that has, it's obviously not a normal canine. And in Eastern African cultures, the primary canine, the tooth down here, is viewed with a lot of superstition. And so a lot of traditional healers will remove that tooth bud or try to remove that tooth bud with some cruel instruments to kind of help with colic and teething and feeding and just crying in the infancy period. And a lot of times what that will do is damage the permanent tooth developing underneath. Kenya also sits on some of the highest highest levels of fluoride in their groundwater. In some areas, like Lake Nakuru, the amount of fluoride in the water is almost 7 times what the therapeutic amount is. So there's fluoride everywhere. And it's great for preventing cavities, but can also result in a condition called fluorosis. And so this young woman I saw in residency, and she had been born in Somalia and moved to Kenya as a refugee in around age 1, and grew up in a Kenyan refugee camp and ended up having these really mottled looking, really pitted teeth. They're not carious. They don't have decay. They're really hard, but you can imagine the social stigma of what these look like. And sometimes the outer surface can break down because the area is just not, the structure is just not good enough. So, and there's no cure for this. You just have to kind of cover them with a plastic covering. So that's my one experience in sub-Saharan Africa. And so we'll move now to a country called Moldova. And they have some similar but different challenges. So when I said I was going to Moldova, my friends were like, where? It's a small country in Eastern Europe. It's landlocked between Ukraine and Romania and has 3.5 million people. So it's about the size, shape, and population of Connecticut. Moldova has often been described as the Mexico of Europe because about a quarter of working adults work abroad. And many of these work in unskilled labor or construction, and 40% live without documentation in these countries. Some are migratory, some stay for years and then come back. The range varies all over the place. These workers are really important, though, because a lot of Moldovan households rely on the money that they send back. Moldova doesn't have a great bustling economy. Their biggest export is wine, and then whenever Russia wants to kind of play with Moldova, they say, okay, we're not going to import any wine, and then the economy kind of collapses. So they don't have anything inside the country that can really support a good infrastructure. It's a healthcare in transition. So in the Soviet era, they had clinics that were both in districts and municipalities, and then from the Ministry of Health as a tertiary system. And most people saw the dentist in these clinics. I don't have a lot of information about the clinics pre-fall of the Soviet Union, collapse of the Soviet Union, because a lot of those records were actually destroyed. However, after 1991, these clinics still exist. Until 1990, Moldovans had actually kept electing a communist government. So everything kind of ran just about the same as it had been for 10 years. And then a new government came in 1999, and the state institutions started transforming into, instead of state institutions, privately run, but still like run by the government institutions. So prices are approved by the government, and they're exempt from certain taxes, which is nice. So that they can kind of exist a little easier. Many dentists from the dental school will work there as compulsory service after dental school. But the Moldovans started to see the rise of parallel private practices. So now there's like two systems. There's a private system and then the state-run system. These private practices face a number of challenges. Banks in Moldova don't have the capital to finance small business loans, and corruption is a huge problem, so they rarely finance small business loans. What this means is to start a dental practice here in the US, it costs about $1 million. By the time you get the building and the equipment and the materials and train the staff and start to produce revenue, it costs a lot of money. So a lot of dentists just don't have those resources. A dentist I work with there, her entire extended family sold all their apartments and homes, moved into a 3-bedroom apartment so that she could finance her office. And then once she was able to work for 10 years, she was able to buy their homes back. So that's how the capital structure works in Moldova. So it's hard to have this private practice model. In addition, dentists who have their education financed through the government are required to pay back service. So they're working in these clinics that people may or may not come to. And they and this is from the official WHO report, in the evenings, weekends, and in their spare time, they treat other patients. So you can imagine that's hard to have some good patient continuity if your dentist is working in one place for the government and then coming back and trying to work for you, and et cetera. As far as financing dental care, there's a national health insurance program that children under 18 and pregnant women have most of their dental services covered. However, everything else is fee for service. You pay out of pocket. I had the fortunate chance to visit their dental school, and you can see the nice hardwood floors. It's like a lovely older Soviet building. It's, again, 5 years after high school, you earn a stomatology diploma, and then you're required to do an internship of it 3 years if you're just doing general dentistry, or 5 years if you're doing oral surgery. Fun fact about the Moldova Dental School, it's across the street from the National Candy Factory, Bucharest. I don't know if that was a coincidence or not. They have no hygienists in the country, similar to Kenya, and their assistants do not receive formal training, but some can have training on the jobs. As far as workforce, they have dentists, which is really great. You can see the Republic of Moldova is that really dark blue line. It sits above the purple line, which is CIS, which is former Soviet countries. But they still lag behind the EU in number of dentists per 100,000 people. So their number of dentists is about 1 for every 2,000 patients. Again, we don't really have any good studies on caries prevalence. One day we will, and this is great baseline stuff for us to start with. But there's no comprehensive adult studies. And in a couple of studies of children at the age 12 and then again at 15, it showed that dental caries prevalence is increasing from right after the fall of the Soviet Union to the modern times. So you can see what this basically means is they looked at kids in 1992 and saw around 2.5 teeth that were decayed in each mouth. And by the time they reached 2 decades later, they're looking at up to 4 teeth that are decayed in each mouth. So that study was done in Chisinau, the capital, but they've recently started to expand, and they haven't published this data, but it's available on their government website, into the rural areas. And in the rural areas, a lot of children are institutionalized. This doesn't mean they're necessarily orphans, but like I said, many families live out and work outside the country, and so what they'll do is they'll institutionalize their children and either visit them on the weekends or once a season when they come home. So a lot of these kids had dental care that they needed. There is a dentist that lives in almost each institution. However, they're not trained to screen the children. They mostly sit and wait till a kid has a toothache to come to them and get their tooth fixed, and probably at that point pulled. In that little conversation on their website, poor education on dental oral hygiene, when they surveyed rural homes, 85% of them didn't have a toothbrush for the kids. So it's hard to do good oral hygiene without a toothbrush. And they also have a cultural thing of pre-masticating food. Instead of making baby food or buying baby food, what they'll do is mothers will chew the food and then give it to younger kids. And this can spread bacteria that cause cavities from the mother to the child. The equipment in these public sector clinics is often outdated and obsolete. A lot of it hasn't been updated or replaced since the collapse of the Soviet Union in 1991. When I was working there, you can see this little red thing in the back. And some people might remember this from dental clinics in the US, but before we had suction, but it's a spittoon, and you're supposed to spit into there. And that's how you take out fluids from the mouth. So those are my experiences, and I really appreciate you letting me share my 2 international experiences with you. And so as conclusion, dental disease is extremely prevalent throughout the world. We're not sure how prevalent it is. We just know it's a huge burden. Public health resources should prioritize prevention as a cost strategy, because prevention is always worth a pound of cure. And it can be really helpful, especially when you don't have a lot of resources to go around. The healthcare systems, as they grow, should recognize oral health as a priority. It's part of our overall health. And so I just think keeping that in mind and not shoving it to the side while these systems are growing would be wonderful. So, thank you. I'll take questions. I think I heard it today. It's 23 cents for a packet for an application of it. 23 cents, that's wholesale from the, we had a rep by earlier today. Yeah. And, a lot of dental companies, we're fortunate here in Minneapolis, 3M is here, and there's some other dental companies that might be willing to donate the fluoride varnish. Yeah. The maximum amount of fluoride is based on their weight, and it's also based on a couple of other factors. One is their risk of getting a cavity. So if a kid has a really low risk of getting a cavity, I don't want to give them a lot of fluoride because I could precipitate fluorosis. Another, the periodicity of it just kind of depends on the kid and their caries risk. And it also depends on where they're getting fluoride from other sources. In the U.S., even if your water isn't fluoridated in your community, you might be getting it from canned peas that are canned in a water fluoridated community. So it kind of just depends. Here in Minneapolis, we recommend it probably at every cleaning for children up until age 18. So. Thanks.
Regarding the fluoride question in Tanzania, I don't think Dr. Denard is here tonight. We invited him to come, but he is a dentist here in town who's done quite a bit of work globally, and he has a fluoride program that I think he takes fluoride from here to low-resourced areas, and so I can connect you by email. Well, continuing to learn more about global dentistry, I'd like to introduce our next speaker, Julio Sotillo. If I'm saying that right, close. Julio is also on faculty at the dental school in pediatrics, and not only does he have a degree in pediatric dentistry, but he also has a PhD in craniofacial dentistry, biology, and so some of his research focuses in that area as well. But I was fascinated because he's going to speak about international adoption and dentistry. Maria, who's going to speak soon, and I practice international adoption pediatrics, and we certainly see many children with craniofacial issues as well as dental issues. So very excited to have you come and speak as well. And Elise, thanks for that overview, public health, from public health perspective.
Okay, thank you, Cindy, for that introduction. I wanted to follow up Dr. Charvis's presentation for you guys. With her presentation, we can certainly appreciate the necessity and the need and the role that we as dentists play, not only overseas, but what happens when these children come to our country in our backyard, right? So relative to that, I think I was going to lead off with this image. I know Dr. Charvis kind of alluded to it a little bit. And she pointed out the fact that, yes, while a lot of research is needed, it kind of sets the precedence for the fact that if I were just to tell you that the different colors represent the amount of cavities in all of these countries, right? If anything, you can appreciate the general diversity of the amount of cavities in any one of these countries, right? And so the difficulty in management of this disease, once it is in the United States, is considering the fact that in some countries there's very little dental disease, or at least relative to cavities. In other countries, it's very, very prevalent, right? And in fact, actually, if you were actually to zoom into the United States, it would be somewhat of a representation of these colors throughout the states of the United States. And some of that might play in with adopted children from all these different countries, but it's definitely something to consider. Now, apart from dental decay, right, I want to also stress the fact that as a dentist, as a pediatric dentist, it's not just about the cavities that we also consider, right? I want to point out the fact that there are other diseases, orofacial diseases, that can in many ways burden the overall quality of life for children. And these are not just limited to cavities, periodontal diseases, tooth anomalies, dental trauma is a subset of head and neck trauma. And so that can certainly be an issue. Mucosal infections, chronic diseases like HIV or AIDS, craniofacial anomalies, and certainly developmental disorders, while it may not directly impact the way that we do the treatment, it might indirectly impact maybe associated behavioral problems that the children may prevent us from doing the treatment. So as far as today goes, what I wanted to do for you is sort of highlight the process of dental development. And in doing so, you might be able to appreciate how the general health problems might relate to these oral problems that the children may exhibit during early development. And I'll also provide some examples of these oral diseases. There might be some pictures, some relatively gross pictures associated with those, so just be aware of that. And at the same time, more importantly, right, what is it that we do as a practitioner to try to help them out, right? Apart from treating the dental disease, how do we prevent it, right? The more important question. What is it that we need to do? So relative to dental development, I wanted to start off with this image. I think what often draws the most attention, and that exact numbers are really of no significant importance, but what often draws the most attention is, when is it that the baby teeth come into the mouth? When is it that they fall out of the mouth relative to exfoliation of primary teeth to accommodate the erupting permanent teeth, right? And what sometimes gets forgotten about is actually the development of the actual tooth, the growth of the tooth itself, right? So if anything, what I want you to note is that during the process of tooth development, right, this begins relative to primary teeth or baby teeth at the 4th fetal month, and it takes about 3.5 years to be complete or so. And likewise, for permanent teeth, this begins at birth. If you look down at first molars, and it takes another 8 years or so to be complete. So if you imagine a child who may be afflicted with some type of disease during this process, the teeth might be affected in any one way. So I'll discuss that in a little bit. So let me, I guess, sort of further clarify this by showing this particular image. Relative to tooth development, there's particular stages associated with this. Initiation, morphogenesis, differentiation, mineralization, and root development, right? So again, now an internationally adopted child, a 2-year-old child that comes into our office, and you think about that child might be having a pre-existing condition or maybe malnutrition or something of that nature, right? A 2-year-old child. If the condition had affected process of initiation, maybe that child would present with absent teeth or congenitally missing teeth. Or maybe during the process of morphogenesis, the teeth might be abnormally shaped. Or during differentiation, maybe the teeth won't have, or mineralization, the teeth will be hypomineralized or hypoplastic. And lastly, maybe the root structure may be affected. So this is all very time dependent. It can affect both the baby teeth and the permanent teeth. And I think the other thing that this image does is not only show you that throughout this process, there are different genes that are involved in this process, there are extracellular proteins that are involved in the process, some of which are ubiquitously expressed throughout the body. And so if there are some type of congenital defects that may be affecting other organs, teeth may also be affected. So something to draw your attention to. So going back to internationally adopted children. Now I'm aware of a varying number of general health conditions or concerns that these children may be affected with, and not limited to prematurity, low birth weight, malnutrition, which result in vitamin deficiencies and other infectious diseases. And all of these in that left column might directly impact teeth. Conversely, on the right side, what you might see is, you can appreciate that maybe depending on age, the emotional vulnerability of these children as they're coming overseas throughout the process of adoption and any other psychological complications or history of abuse, developmental delay, and behavioral problems, these issues might affect the way in which we deliver the dental care. Okay, and I'll touch on that in a little bit. And so what is it that we're looking for specifically relative to these previous issues and concerns to the general health? From a dental perspective, certainly during development, I alluded to the fact that the enamel and dentin might be affected and consequently you might develop cavities or caries. Periodontal disease is an issue, and mucosal diseases like aphthous lesions or canker sores can happen. Candidiasis, which is fungal infections, and herpes or intraoral viral infections. You can certainly, as I alluded to earlier, have perioral trauma associated with abuse, cultural practice, which Dr. Sarvis alluded to, relative to the extraction of the canines or premastication. And certainly dietary habits are different in other countries relative to the United States, which may, in fact, directly impact the development of teeth. And certainly fluoride exposure, Dr. Sarvis spoke in regards to too much fluoride, right? Sometimes too much of a good thing is not necessarily a good thing. And I guess relative to pictures, and what is the things that you may be looking out for so that when the referral is appropriate for a dentist or a pediatric dentist, these are some things that you might want to be looking out for. I alluded to the process of dental development, and again, dental hypoplasia is a consequence of dental process of disease, and the relative layers of the tooth might be compromised. Fluorosis is all dependent on the amount of fluoride you're exposed to, and there's a very spectrum of this particular issue, right? Where the image on the left, you have very mild fluorosis, kind of a white splotchy areas of the teeth, and certainly the one on the right, which is more of a significant aesthetic issue, you have that discoloration with even some pitted areas, right? All of which can be addressed, but in some circumstances can be a financial burden, on families if it needs to be addressed. Dental decay is obviously a problem, or can be a problem within this population, and it's also a spectrum of the disease. The mildest version, you have sort of the decalcification. So if you notice on the top picture, the white area along the gum line, that's decalcification or the beginning of a cavity, something to look out for. Once it becomes cavitated or sort of a hole within the tooth, it might become more moderate, or certainly on the lower right picture, it's certainly more severe, right? More generalized. You have different patterns of the disease, the colors, etc. And then even at the gum line, you see on the upper right area of that picture, you have a certainly gum infection associated with that. Apart from caries, periodontal disease can happen in children. Gingivitis being probably the mildest version of this disease. You have those gums that are pretty red, pretty angry. Toothbrush will make the gums bleed. You floss, it bleeds again. That's an indication or a pathognomonic for gingivitis. Sometimes gingivitis comes along with caries. I mean, certainly if you're not brushing the teeth, you're not brushing away the bacteria that end up causing the dental decay, so that can be a problem. And certainly the picture on the lower right is all permanent dentition. And myself as a pediatric dentist, I try to focus on instilling the idea not only to the child, but also the parent, right? That oral hygiene is extremely important. So that way we don't get to this particular stage later on in life. So that's an extremely important aspect of the nature of our practice that we do for children in the United States and those that are adopted from overseas. Mucosal lesions, which can sometimes happen independently or in association with some chronic conditions. More often than not, in those conditions where a child may be immunosuppressed, right? So canker sores or aphthous lesions, candidiasis. Thrush doesn't just happen on the roof of the mouth or on the tongue. It can happen anywhere within the mouth. Herpetic-like lesions on the lip, and can also happen within the gum tissue. Very uncomfortable child, not eating, drinking, fever, etc. So it's a significant problem that a child can be dealt with as a burden because of oral disease, not just cavities. Right? And so ideally, what should the process look like, right? In development, this interprofessional relationship, that we look for in trying to address the children, the care that they need, etc. And there isn't a lot of research out there, as Dr. Sarvis alluded to, but there are some journals that have suggested that as part of a post-placement medical evaluation of internationally adopted children, dentistry should be incorporated into that aspect, right? And from our perspective, from the Academy of Pediatric Dentistry and the Academy of Pediatrics, it's suggested that we do this referral no later than the first birthday, right? And so more often than not, the common question is why so early? Why by the first birthday? You know, they only have maybe a couple of teeth or so. What is the significance behind that? And what we often focus, or the most important aspect that we focus on this particular early age, is the fact that, well, yes, we do the exam, we take a look at the teeth. We also take the time to educate, right? Educating of the parents, making sure that they understand oral hygiene process, brushing, how much toothpaste to use, right? How much is too much. That's extremely important. Also, things like anticipatory guidance, right? So if a toddler, learning how to walk, etc., you know, they're pretty top heavy, they fall down, what happens? The teeth are often the sites that are affected. And so how to manage those, how to triage those things, that's where we kind of allude to the factor in this particular. So by the first birthday is extremely important. So that way I can't probably stress enough how often I see a 2-year-old child, a 3-year-old child that comes to the office or the dental clinic with decay, right? By that time, it's too late. There's something that we could have done earlier on to try to address and prevent that problem, right? And so that's where our role really fits in. Another thing to consider, certainly during the referral process, is that the AAPD has this sort of guide adapted for physicians and other practitioners alike, right? And what you note is that those children that are a recent immigrant, whether it's through a family or adopted, right, they're placed under what is otherwise a high caries risk, right? So another reason for a referral. What is it that we consider as a dentist or a dental practitioners? I mean, certainly the establishment of a dental home is extremely important. Again, providing all the needs, the exams, the education to the parent and the child alike, anticipatory guidance, trauma, and the appropriate referrals if they're needed. And apart from this, if we do find disease, dental disease, right, we are often presented with the notion of, okay, well, based on the overall health and well-being of the child, the behavior, the cooperability, how is it that we're going to do this treatment? Sometimes it's okay to do it in the dental office. Sometimes we have to do it in the dental office with conscious sedation. Or alternatively, we might have to put the child to sleep in order to best or comprehensively treat the child, right? So it's not just about drilling and filling, but it's comprehensively treating the child to meet their needs. Everybody here knows and certainly understands what is it that we do from dental decay perspective, filling crowns and etc. From a mucosal perspective, more often than not, these are managed palliatively, right? You know, pain management and some antivirals, antibacterials, and antifungals. Prevention, extremely important. And by that, I mean it's purely education. Educating the parents, the caregiver, I should say also, and the children about what is it that we can do to prevent any ensuing disease or any future disease, right? Extremely important. And certainly behavior management in terms of how is it that we're going to deliver the care that that child may need. So to sort of conclude with a take-home message, if anything, I want to impress the fact that it's not just about dental cavities. There's many other diseases that the children can present with. So, you know, be a lookout for some of these oral-facial diseases. And relative to a referral, right, it's important to establish that dental home early and early enough by the first birthday, right? So that way we can impress upon the fact of educating the process of oral hygiene and trying to prevent this otherwise, you know, very preventable disease. If anyone has any questions or any concerns, you can feel free to send me an email, give a call, whatever it may be. And I think that's all I have. Unless there are any questions.